This time we're going to do our Master of Ceremonies talk, Dr. Woldering, and then we'll have the break after it. I've come to know him at 30 years that I've come to decide that it's no surprise he has 17 patents, and you always think of mind is a terrible thing to waste, sleep is a terrible thing to waste with Dr. Woldering. As you all know from the website, I think he gets up about 4 in the morning to answer emails. It drives me. I get nervous just opening up my computer. So now we're going to hear from Dr. Woldering on a topic that he has really, I'd say, pioneered in terms of the work with neuroendocrine tumors, which he started as far back as Ohio State University when he was working with tissue and uniquely perfusing tissue, bringing something inside a bottle to almost an actual, what they call in situ state. In other words, creating physiology around the tissue, but doing it in a beaker. So he's going to share with us what's new, what's old, and where the future is going. Dr. Woldering.
Yeah, that's why I had you. Michael, let me know when you're ready. You ready? Cool. All right. Like Otto said, I've had an interest in trying to be able to create models using human tissue to replace doing rabbits and mice and rats, because I'm not a vet. I don't treat rats and mice and dogs and cats. I treat people. So what I've tried to do is save tissue that would have been thrown in a vat of formaldehyde and cooked, pickled as it were, and be able to use that tissue to tell us things that I can then turn around and use in the patient that the tumor came from. I'm trying to use the tumor as the guinea pig, make the tumor in a test tube sick, and keep you well. And that's the concept of today. Well, what do we study and why do we study it? And clearly you've heard a lot about chromogranin A and synaptophysin stains. Well, what do these stains really tell us? And it's sort of like looking at you and your sister or brother and saying, are you identical twins? Are you fraternal twins? Or are you just plain brother and sister? The more you look like your family, i.e. the more your tumor looks like the cells that it arose from, the better it behaves. If your tumor, you can't tell whether it came from the colon or the breast or the lung or the brain, you're in trouble. That's called an undifferentiated tumor. If, on the other hand, you look at a tumor and you say, oh, I know that tumor came from the breast because it looks like the cells that make the milk ducts in a breast. That's a well-differentiated tumor. And those are the kind of things that define the behavior of tumor. The more you look like your family, the better you behave. Okay? The other thing that we talk a lot about is called the Ki-67. The Ki-67, or proliferation rate, says I look at a slide of your tissue and there are cells that are divided. And those cells can be picked up by a stain called the MIB1 or the MIB1 stain, or the antibody is the MIB1 antibody. And the test is called a Ki-67. And basically it says what percent of your cells are actively dividing at the time we made this, took this tumor out, pickled it, and made it onto a slide. Obviously, if you have 1,000 cells and 1 cell or 2 cells are dividing, that's a better behaved tumor than if 100% of your cells are actively dividing in that same slide. The other thing that we do is I have a specific interest in angiogenesis. Angiogenesis is new blood vessel growth. And the stains that are used are called CD31 and factor VIII. And they tell us how many blood vessels are in the tumor per high-powered field. Then the other thing we do is take living tumor and we do what's called drug resistance testing. And that is, we bathe the tumor in incredibly high concentrations of a chemotherapy drug. And if it doesn't kill it at incredibly high concentrations that you couldn't achieve in the body, then we know that tumor is resistant to that drug. We also can make your tumor grow blood vessels, and I have a half a dozen patents on being able to take your tumor and grow blood vessels from your tumor. And the newest thing that we're doing is asking the question, are the blood vessels that grow from your primary tumor the same as the blood vessels that grow from your lymph node? Are they the same as the ones in your liver? Because if they're not, now we are in deep doo-doo. Because that says that a therapy that works in your ileal primary may not work in the nodes, and the one that works in the nodes may not work in the liver. So that's important to know. And then finally, you heard yesterday implications that in the future we were going to be able to look at gene expression and ask, what genes are in my tumor, and are the genes in my small bowel primary the same as the genes in my lymph node, the same as the genes in my liver? And I'm going to show you some terrifying information that says that may not be true. Why do we do these tests? Quantitative chromogranin and synaptophysin determines differentiation. It tells you how much your tumor looks like the cells it came from, and it determines how it behaves. Ki-67 we talked about, and we talked about the CD31 and factors VIII. A lot of times when you heard Dr. Mitros yesterday and me, you'll hear about an HPF, or a high-powered field. And what is that? When a pathologist looks in the eyeballs of the microscope, what he sees is a field. It looks like a little square with cells in it. And they can adjust how much magnification, and that's called a high-powered field. All right, we're going to talk today about important things, because you guys call me and are surprised that we can go back and use tissue that's 10, 12, 15, 20 years old, and that's the fixed or dead tissue. And then there are some tests that we need living tissue. We need to be able to grow cells, we need to be able to grow blood vessels, etc., and we're going to talk about those today. The following tests require dead tissue. This is the biopsy you had when Noah was building the ark is still good. Okay? And this is my mom's lymph node in her neck. And you can see the brown stuff are cells that stain with chromogranin. These are what are called a +3 stain. And this is an indicator that her tumor was very well differentiated. If you now look at a piece of primary tumor, lymph node, and liver, notice there are 3 columns. And notice that the yellow is where it's positive. Look across and see how few tissues are the same all the way across. And then look in the far right column, the range, and you can see the percent of people that have intense +3 staining with chromogranin varies from 1 to all the way up to 90. And those are the differences. Look at number 11. The liver met has 10% of its cells that are chromogranin positive, but the primary tumor has 100%. The important thing about these slides that I'm going to show you is they were all taken out on the same day by the same surgeon, processed by the same technician, read by the same pathologist in the same setting. So you can't argue that Dr. Schmo read this tissue and Dr. Ryan read this tissue. These are all done at the same day by the same person. So again, out of 13 patients that we studied, the difference is 90% in the chromogranin staining. So what you see in your primary tumor is not necessarily what you see in the node. Why is this important? Because it says in the old days we only sampled one tissue. If you got a liver met, we biopsied a liver met and that's all we ever did. And we said you never needed another biopsy, and that may not be true. What about synaptophysin? Again, my mom's neck node, 100% of the cells stained +3 positive. You can see all the brown cells, and you can see the nuclei are the dark blue things, and the lighter blue things are little septi in the lymph node. Again, look at the things that are yellow. Look at the things that match all three columns, the primary, the lymph node, and the liver metastasis, and you can see that there are just a few of these that have all that are exactly the same. And the range of differences between the primary, the node, and the liver met range from anywhere from 0 all the way up to 95. Again, a summary, 13 patients stained. The maximum variation from tumor to tumor in a patient ranges up to 95% difference. So it's not a little subtle difference, and I'm going to show you a subtle difference in Ki-67. In chromogranin staining, what the pathologist looks at to tell you whether or not you have a well-behaved tumor may be vastly different if you just do one tissue. And this is Ki-67 in my mom's lymph node in her neck. As you can see, the black spots are the positive cells that are dividing. The blue cells are not dividing. And again, now we're going to show you the opposite side of the coin. Again, this is the same lymph node you're looking at, chromogranin, synaptophysin, Ki-67, and you're going to see that Ki-67 is much closer, whereas there's a huge variation between chromogranin and synaptophysin, not so in Ki-67. And now notice a lot more of them are yellow all the way across, and the range difference is only 5% in the biggest one. Now, we had a patient this last week who had a 40% difference among tissue. And that's the first time out of hundreds and hundreds of patients we've now studied that I've seen that big a difference in their Ki-67. Again, 13 patients studied, only 5% difference. So remember that traditionally the, quote, typical type of carcinoid, the best behaved carcinoid, was less than 2%. 3% to 20% were called intermediate. And so all of these patients are either very well differentiated, low proliferation rate, less than 2%, or a few of them up to 5%. What about blood vessels? Blood vessels aren't tumor cells, and you would think that since the blood vessel in my nose is directly connected to the blood vessel in my ear, is directly connected to the blood vessel in my heart, is directly connected to the blood vessel in my big toe. If I'm a red blood cell and I hop on the train in my ear, I can travel all the way to my little toe, back to this ear, cross the brain, back through the heart, etc. It's all one giant tube. So the characteristics of that tube, you would think logically, ought to be exactly the same. One blood vessel ought to be in your nose, ought to be the exact same thing as a blood vessel in your toe. It's just not true. And this is evidence again that the CD31 staining characteristics, the number of blood vessels per high-powered field in your tumor, differ, and I'll show you the same thing is true in the factor VIII stain. And again, 60% variation between different tumors in the same individual. And this is factor 8. It is the opposite stain, but looking for the same things. How many blood vessels per high-powered field? The range is a little bit different. Again, 13 patients and about a 25% change in the difference between your primary lymph node and liver met. What does this again tell you? What it says is sampling is everything. The pathologist, who I have immense respect for, and I've always been looking at tissue from the very first time I worked in the lab at the NIH. The pathologist tells you, and it's sort of a quip, the accuracy of their diagnosis is proportional to the amount of meat on glass. The more of your tumor they look at on glass slides, the more accurate their diagnosis. And this is proof that you may need more than one area sampled to get the optimum diagnosis. Now, the following tests require live tissue. And this means that I can't take the stuff that you had biopsied before Noah built the ark, and I need to bring you in and I need to open you up or stick a needle in something to get enough tissue to do these tests. And have you ever wondered why, when we give people chemotherapy or whatever, that we rarely, if any, ever cure anybody? I mean, yes, there are cures with chemotherapy, testicular tumors, some lymphomas, things like that. But if you have breast cancer, the chance of chemotherapy curing you if you have widespread metastatic disease is approaching 0. The same if you have lung cancer of the garden variety. The chance with widespread metastatic disease that chemotherapy is going to cure you is almost 0. And the question is that because every tumor in your body may be different than its brothers and sisters? And one of the elegant pieces of data that says that may be true came from a guy named Daniel von Hoff. Dr. von Hoff and I were at the NIH together. He went to San Antonio and built an empire of studying tumors, and then went to Arizona. And basically what he did was he looked at 3 tissues. This is our work. Whoa, I'm missing a slide. Okay, this is our work. 3 tissues from 13 patients that we tested against 9 different chemotherapies and generated 82 drug sets. And we tested all kinds of chemotherapy drugs: cisplatin, dacarbazine, doxorubicin, or called adriamycin, etoposide, 5-FU, gemcitabine, interferon, all these kinds of things. If you look at it, what you look at as the bottom line is the last sentence on this page. Only 6% of tissue exhibited susceptibility to a single chemotherapy agent in all tumor sites. That's sort of scary. It reinforces the concept that we need to think about your primary tumor potentially being different than your lymph node, being different than your liver metastasis. So we need to sample more tissue to get more information to be able to personalize the chemotherapies and the other therapies that we give you. And basically, just look over on the right-hand side. These are 0 out of 3 tissues. The 3 tissues are primary lymph node and liver. And notice that the chance that they're not congruous, in other words, they're not sensitive to the same thing, ranges from 0% to 100%. So again, your drug resistance testing is totally different in many of the cases. Well, what we look at in our laboratory is blood vessels. We look back and say, you know, we've been trying to kill cancer cells since at least, I don't know, 100 years. And so far, we've not done such a hot job at being able to say, here's a cancer cell, here's a therapy, and we're going to be able to kill them all. So the question is could we potentially choke off a tumor and kill it? Or I'd be just as happy is could I put a tumor into a state of dormancy where it can't grow and it can't spread? Remember that you sort of win two ways. If a tumor shrinks, you win. If the tumor doesn't grow, you win. You only lose one way, and that's if the tumor grows and metastasizes. And so we've tested a group of agents that are investigative agents, some of which are on the market, some of which are things like black raspberry and Chinese sweet leaf tea that are herbal kinds of things, curcumin, turmeric, etc. And we've tested hundreds and hundreds of things in these assays. How does the assay go? Well, basically we put a fragment of your tumor in a blood clot without blood. It's basically what we call a fibrin thrombin clot. See the little blood vessels growing out of the tumor? And these are in the lab affectionately known by my lab students as my chia pets. We ask the question, do they grow? And if so, how much do they grow? You can see that we have a scoring system that goes from 0 to 16. And on the right, you can see the chia pets. All those little hairs are true blood vessels. They have lumens, they anastomose, they branch, and they grow, and we can grade them, we can inhibit them, etc. This is an example of a patient who had their mesenteric tumor sampled. They would have hopefully had their small bowel sampled, and oftentimes liver metastasis sampled as well. You can see the agents that we treated here, things like Gleevec, which are not used for neuroendocrine tumors. But in this set of experiments, we were looking at the ability of that drug to inhibit blood vessel growth. You see RAD-001 is Afinitor or everolimus. You see Taxol, you see colchicine, you see Chinese sweet leaf tea. You see a drug that Odoricio and Lola Anthony tested, which is called PTK787, which was a tyrosine kinase inhibitor. And all these things, green represents the percent of the wells that I plate that begin to grow. Red is how much do they grow, and the blue lines are the combination of green plus red. And so we can now say that in this patient, the most effective thing may be a drug called Apothelone B, which was a drug that was put into early stage clinical trials by Novartis, a very effective drug, but ultimately was dropped out of clinical trials. Well, once we've done this for many, many, many patients, you can see here is a drug called Apothelone B that we're analyzing. The blue dots are the untreated controls of 60 patients that we treated with Apothelone B. You can see that it creates a curve going from not very angiogenic to very highly angiogenic. And the red lines, the red dots, match the blue dots. Then the red dots are treated. So you can see there's an occasional dot that's not on the bottom line. It's not suppressed. That patient would not be a good patient to use Apothelone in. On the other hand, you can see that many patients completely inhibit their blood vessel growth when their tumor is exposed to Apothelone. And what you can do now is do the slope of the control curve and the slope of the treated curve, and you can now start calculating what percent response rates you think that drug would have. It's sort of like doing a clinical trial in a test tube rather than a clinical trial in patients that would make them sick. Well, do we have evidence that tumors vary at the level of a gene? That's pretty basic. Remember, you have to have a gene have an expression of a protein, you have to have a gene to make a receptor. You have to have a gene to have an mTOR pathway. You have to have a gene to have a tyrosine kinase pathway. And if you don't express the gene, you don't have that pathway. Or if you have that expression that is a normal level, you have a different response potentially as a person who has overexpression of a gene. It makes sense. Genes are expressed in the number of copies. So if you have one gene, you make a certain amount. But if you have 10 copies of that gene, you should be making 10 times as much of that receptor, protein, or whatever. So genes are often talked about in underexpressed, normally expressed, and overexpressed. So if you want to create a target, maybe what you want to look for is a gene that's overexpressed, and you want to find a drug and that will work on that gene pathway so you can kick the tumor's butt. So we've talked a million times this conference about somatostatin receptors. Remember, there are 5 somatostatin receptors, SST 1, 2, 3, 4, 5, and we studied the somatostatin receptor gene expression in the primary tumor, the lymph node, and the liver met of patients. Okay? Now, what we did was very unusual. In other words, most of the time when people study gene expression, they grab a piece of tumor and they say, oh, here's the gene expression or the gene copy number in this tumor. And I said, well, wait a minute. What if the small bowel that you arose that primary tumor from also has somatostatin receptors? Maybe we ought to subtract the background of the normal tissue from the combination of the tumor plus small bowel, okay? Same way with a lymph node. Maybe lymph nodes have gene expression for a factor and that we need to subtract out, or liver. And so what we did was exactly that. We took normal lymph node and we took lymph node plus tumor and we subtracted the genes that we found in the normal lymph node from the genes that we found in the combination lymph node tumor, because a lot of times you can't be 100% sure that you have pure tumor in a node. There's some lymphocytes and things that Dr. Mitros talked about yesterday that infiltrate the tumor. So we're trying to negate or black out the background. Okay, we did it with lymph node, we did it with small bowel. Again, subtract the background from the tumor, and then we did the same thing for the liver. Somatostatin receptor subtype 2 was overexpressed in about 70% of the specimens. Turns out that 4 out of 4 livers, 3 out of 4 small bowels, and 1 out of 4 lymph nodes had overexpression of somatostatin receptor subtype 2. The other thing that, like the octreoscan or octreotide or sandostatin goes to is SST5. Same kind of thing, lesser extent, 50% of the specimens, 3 out of 4 livers, 2 out of 4 small bowels, and 1 out of 4 lymph nodes. Somatostatin receptor 3 and 4 were variable, and 1 was only seen in men's. Now this looks complicated, but it really isn't. If you look at the red, and you notice over on the left are small bowel, lymph node, and liver, and then you have 4 patients across from top left to top right. And you can look at somatostatin receptor is a red line, meaning it's overexpressed in patient 1, top left corner, in the small bowel. And then you can look at right below that and look at SST2 is expressed in the lymph node, and SST2 is expressed in the liver in patient 1. Now look at patient 2, the second set of columns. SST2, 9.9, overexpressed. Lymph node, no somatostatin receptor subtype 2. And in the liver, again, somatostatin receptor subtype 2 is not overexpressed. There's 1, there's 5, there's 3, but no somatostatin receptor subtype 2. Isn't that scary that your primary tumor has somatostatin receptors, but the lymph node that came from that primary tumor doesn't have somatostatin receptor subtype 2, and your liver met from that same tumor at a gene level doesn't have SST2. Very scary. These are upregulated genes. Okay? Notice that there is another gene here that nobody's ever talked about, to the best of my knowledge, at any of these meetings, and you're hearing it for the first time. And that's the gene called FGFR3. Look at the top left, right above SST2 in column patient 1, small bowel, see FGFR3. Look in the right below that in the lymph node column, FGFR3. Look in the liver column 1, FGFR3. So there it's called fibroblast growth factor receptor 3. Turns out that that may be a really good target for us, and that may be important. Now, not only do tumors get upregulated, but tumor genes get downregulated. And that may be important because everybody knows how to make your Corvette go faster, right? Anybody not know how to make your Corvette go faster? The answer is you take the damn foot off the brake, right? Nobody ever thinks of that. They think of the accelerator. Nobody ever thinks you got to take the brake off. So if you inhibit the inhibitor or you upregulate a downregulated gene, may be equally as important in downregulating an overexpressed gene. Okay? So here we have other things that likewise, notice in column 1, we see things that are in the small bowel, the lymph node, and only one, IGF-1, is expressed or underexpressed in all 3. Well, how do we use this information? Well, all the stuff we talked about, we use chromogranin and synaptophysin to determine differentiation. We use Ki-67 to tell us potentially how aggressive or how fast our tumor is going to grow. We tell the number of blood vessels per high-powered field. The CD31 and factor VIII stains tell us how much oxygen and nutrition are getting to our tumor. No oxygen, no food, no growth. No blood vessels, you can't grow. Remember, they say in an adult, there are no new blood vessels except during the menstrual cycle of women. If you're a man, once you reach puberty, you don't make any new blood vessels the rest of your life. So it is a very stable system. How do we use the drug resistance testing? Well, nobody's quite sure yet. Certainly, if I was faced with a decision for myself, and I said, my tumor is completely resistant to drug X, I don't think I'd let my doctor use that drug on me. Now, their argument is, well, what about the opposite side of the coin? If the testing says you're not resistant, that you're, quote, sensitive to that, about 60 to 65% of people respond to that drug in series by people like Dan Von Hoff, etc. Well, here we go. Could I take that FGFR3 data and can I really see that it works in human blood vessels? Because now I found something totally by analyzing genes, and I didn't know anything about FGFR3. It was like, who dat? What's that? I don't know what that is. So I had to go find a drug that would target FGFR3. And it turns out Novartis has a drug called Davitinib, and it's been in some clinical trials for non-neuroendocrine stuff, And so as you can see, as you go up on the blue line from the dose of 82 to 165, you can completely block human blood vessel growth and the blood vessels we get from human placentas. So we then tested 35 neuroendocrine tumors against davitinib, and you can see the two slopes of the line. The black is the control untreated. Every dot has a black dot has its matching treated blue dot, and you can see how effective davitinib is against the black line tumor, i.e. all these neuroendocrine tumors. So here's something that I didn't know what davitinib was. I went to look for davitinib based on needed a drug that inhibited FGF. These are the kind of leads that we're going to use in the future to personalize your care and to develop new drugs. Here again is the growth effect of davitinib and the overall effect when you look at its ability to inhibit how many begin to grow and how much they grow. As you can see, there are a couple patients who don't respond, their tumors don't respond to davitinib, but most of those purple dots on the bottom are right on the bottom line. And you can calculate the responsiveness to the tumor. And in this case, the difference between the slope of the black line and the slope of the purple line is 91% inhibition. That would be a hell of a drug. Not yet in clinical trials for neuroendocrine tumors, but we're going to try to do that. And again, here's a summary of FGFR3 expression. Notice we have 8 tumors here that we've done gene profiling in, and there's only one tumor FGF is not overexpressed in, and that's patient 7. Everybody else looks like, at least in 2 out of 3 or 3 out of 3 of their tissues, that it's overexpressed. You gotta support research. Trust me when I tell you, the NIH ain't coming to rescue you. The American Cancer Society ain't coming to rescue you. We have to rescue ourselves. We have to go out, we have to develop the philanthropy to support people who are doing carcinoid research, neuroendocrine tumor research. I'm not just trying to get money for my lab. I am trying to support people like Herbert Chen in Wisconsin and all the people who are doing basic science research in neuroendocrine tumors. These are the guys who, if you don't support these people, 10 years from now you're going to say, why is there no progress in this disease? Remember, the Komen Foundation was an idea, Race for the Cure. They have raised billions, literally billions of dollars for breast cancer research. A very fast-growing tumor, and they've raised a lot of stuff. We don't have fast-growing tumors. We have slow-growing tumors. We're going to crawl for the cure. Thank you very much.